On to next speaker, Dr. George PUTHURAN, who is again Chief of Glaucoma Services located in Arvind Eye Care Systems of Madurai. And of course, we all know that he's an amazingly prolific surgeon with a lot of innovative skill sets with him. And he is going to be telling us something more interesting, glaucoma surgery and tiny tots and the guidelines on the choice of surgical procedure and how to do a safe surgery. On to you, Dr. George.
Thank you very much, Chitra ma'am. And surgery is a critical component of the management of childhood glaucoma. It is important to prepare patients and parents or caregivers for lifelong follow-up and possible future surgeries. Glaucoma surgery should preferably be performed by a trained surgeon in centers where there is sufficient volume to ensure surgical experience and skill and safe anesthesia. So a lack of familiarity with the ophthalmic eyes is associated with more complications. Children generally have lower surgical success than adults, except for angle surgery where the opposite is true. An aggressive inflammatory and healing response in children is thought to account for this fact. Lastly, lack of cooperation affects the degree of monitoring and post-op follow-up, which can compromise surgical results. There are a number of surgical procedures to choose from, with varying indications as well as advantages and disadvantages. Angle surgery, goniotomy, trabeculotomy, conventional and circumferential, combined trabeculectomy, trabeculectomy with mitomycin, and aqueous drainage implants. There are very few randomized surgical trials in childhood glaucoma, and in the absence of these trials, consensus becomes very important. I have included in this presentation perspectives from the Worldwide Childhood Glaucoma Surgical Survey conducted by the World Glaucoma Association. This survey is the largest ever worldwide survey of childhood glaucoma experts who manage between them a considerable number of patients with childhood glaucoma. This data provides an informative and important glimpse of practices among childhood glaucoma surgeons. Goniotomy was selected as the procedure of choice for primary congenital glaucoma by 28% of experts. Trabeculotomy was selected as the procedure of choice for primary congenital glaucoma by 41% of experts, with 28% of them preferred the conventional probe technique and 13% the circumferential trabeculotomy. Combined trabeculectomy was selected as a procedure for treating PCG by 14% of experts. I am by now totally convinced that the first operation has the greatest chance of success, especially in primary congenital glaucoma. Whichever operation is chosen, the technique must be safe and it must be one that works in your hands for your population. Angle surgery is the procedure of choice for primary congenital glaucoma with the exact choice dictated by the corneal clarity and the surgeon's experience and preference. So goniotomy in PCG, if cornea allows satisfactory visualization of the angle, most effective between 3 and 12 months of age, and the obvious advantage that it does not violate conjunctiva and prejudice success of future surgery. A conventional 90-degree to 110-degree probe trabeculotomy is the initial procedure of choice in our cohort of children with PCG. The advantage of trabeculotomy is that it could be used in all cases of glaucoma in children, regardless of corneal clarity. So accurate localization of the Schlemm's canal is the key. A partial thickness scleral flap is fashioned, and Schlemm's canal is located under high magnification by slowly and carefully deepening while spreading the incision walls of a small radial incision at the limbus near the gray zone. Successful entry into the Schlemm's canal is often accompanied by a reflex of blood and or aqueous from the cut edge of the canal. A Harm's trabeculotomy is gently inserted along the course of the canal, and when completely inserted, the probe is rotated towards the anterior chamber, breaking through the remaining trabecular tissue with virtually no resistance. The greatest challenge of the procedure is to correctly identify the Schlemm's canal. The canal is found in the corneoscleral sulcus at the blue-gray-white transition between the scleral and the corneal tissue. Using high magnification, a cellulose sponge can dry the junction and allow for the appreciation of droplets of clear aqueous bleeding precisely above the canal. A radial incision 2 millimeters length is made at that point. If the surgeon is unsure of the landmarks, it is possible to extend and deepen the posterior end of the radial incision until the choroid is seen. Carrying the incision anteriorly from that point allows the surgeon to see the scleral spur, and the canal is just in front of the spur. An alternative to the traditional metal trabeculotomy approach, which incises up to 1/3 of the Schlemm's canal, is to use a blunted suture like a 6-Uroprolene or an illuminated microcatheter to incise 360 degrees. Circumferential trabeculotomy is advocated and is becoming increasingly popular as the entire angle is treated in one session and surgery therefore does not have to be repeated. CTT, combined trabeculectomy, is argued to be more successful than either procedure performed alone, although there are no prospective comparisons to support this assertion. CTT has been associated as a primary procedure of choice in populations which are thought to be at greater risk of failure because of more severe or advanced presentation, such as in the Middle East and India. Glaucoma drainage device surgery is an important part of therapeutic repertoire in childhood glaucoma, especially in failed angle surgery or as the first surgical procedure in certain secondary childhood glaucomas. GDD surgery was the preferred primary operation chosen by 44% of experts following removal of childhood cataract, whereas after failed angle surgery, 53% of experts preferred it as the next surgical option. There are certain clinical scenarios, like in this tiny tot with a 15mm cornea, refractory glaucoma post-failed angle surgery, where we will need to risk an aqueous drainage implant. And in our constant endeavor to make tube surgery safe even in the very young, we have found that embedding the tube in the patient's own sclera minimizes the otherwise dreaded complications of tube exposures, extrusions, and endophthalmitis. A caveat is to have a needle-generated scleral tract of sufficient depth and length so that the tube is buried well inside the scleral tissue. There is an intimate relationship between corneal pathology and glaucoma in childhood glaucoma. As corneal clarity is profoundly affected by IOP, reducing IOP before turning to cornea surgery is advocated. Successful glaucoma surgery may eliminate or delay the need for corneal grafting. If corneal surgery is contemplated, IOP should be addressed first. To conclude,
1 minute remaining. Sir.
Surgery is the mainstay of treatment for childhood glaucoma, is most challenging and is inevitable in the child's lifetime. Just as there is variation in the way children can present with glaucoma, there is also variation in the approach to surgical treatment. Considering that multiple surgical interventions are likely, whatever the approach, the need for long-term surgical strategy and algorithm of action is essential. Surgeons need to modify and develop a technique that is safe and works in the surgeon's hands in order to balance increased success with decreased complications. Thank you once again for the opportunity.
Thank you very much, Dr. George. It was an amazing talk. And I'm going to ask our pediatric ophthalmologist, Dr. Murli, to take one question, because I think we have a number of speakers ahead. We have to move faster. Dr. Murli.
Dr. George, what is your tonometer of choice for these kids? Do you use the rebound tonometer?
Murli, I didn't get you.
No, what is the tonometer of choice for these kids, sir? I mean,
Yeah,
do you
we
use the
we now
rebound?
use eye care, Murli.
Okay, and if the corneal diameter is more than 14, should we still try the angle surgery or should we straight ahead go for trap?
I would still try. If it's the first procedure of choice, even with a 14 millimeter cornea, I would still try a trabeculotomy first, Murli, before. What did you say before? Before we go for a
Trab.
no. I would prefer to try a trabeculotomy first.
Okay.
Thank you.